Hello and welcome to Aspen Physician Spotlight. My name is Vikram Christian. I'm a pediatric gastroenterologist at the University of Minnesota in Minneapolis. And today I have the honor and privilege of interviewing Dr. Robert Martindale. Dr. Martindale, welcome. Thank you for taking the time to talk with me today.
Thank you. Thanks for doing the interview. That's great.
Dr. Martindale, definitely not a stranger to the Aspen community, but he is a professor of surgery in the Division of Gastrointestinal and General Surgery at the Oregon Health Sciences University. So, Dr. Martindale, I actually wanted to start off, and this is something we've been doing for a lot of our interviewees, is to talk a little bit more about, I guess, how you got interested in nutrition. What led you to a career in nutrition?
Oh, it's a circuitous route, sort of like all the things in my life, it seems like. Uh, I wasn't planning originally to do nutrition. I was working in a lab at UCLA during the summers when I was going to school in Northern California to be a forest ranger. And I worked in a lab at UCLA in the summertime to make a few dollars to pay for my time up in the forestry school. And I got very interested in human physiology. And so my major professor, when I was finishing my undergraduate degree, said, we'd like you to come work for us and come to UCLA, as a grad student. I said, well, not sure. But anyway, so I ended up joining the nutrition department at UCLA to get a PhD. So that's how I got into it. But it was purely by chance that my professor said, we'd really like you to come back here and work rather than going on to forestry. I said, well, no, I'm still going to do forestry. He said, why don't you apply for the master's program or PhD program and just see how it goes? So I did. And that's,
Oh,
so
interesting.
I'm
So
no longer a forestry ranger.
that's thankful for that. So it's quite a big jump from a forestry ranger to working in a lab. What were you working on at that time?
In those days, we were doing the isolated perfused pancreas. I worked in a lab in a building which had people that were amazing, brilliant people who were discovering new things all the time. And I found the whole environment at the lab to be very exciting and,
Mhm.
understanding. And we had a Martin Grossman who won the Lasker Award, which is a prestigious award. And so he was a co-discoverer of H2 blocker with Dr. Gregory from London. So there were two of them. And, starting to work there and being around these people that seemed to love their work and love their job. And I thought this might be a good fit. So ended up
Mhm.
staying on for a PhD program.
Wow. And then how do you make the jump from there to getting into surgery and then nutrition?
Well, I when I was finishing my PhD degree, I interviewed for a job at University of California, Berkeley, and because of the politics at the time, they were not offering tenure. And I had a
Hmm.
child at the time, and I said, I'm not sure I can, work somewhere where I and I'm guaranteed tenure. I was worried about having a job, as
Hmm.
just a PhD alone. So all of my colleagues who were MD PhDs all said, "Man, just go to medical school." I said, "No,
Hmm.
no, I don't want. That's I don't want to spend 4 more years." Oh no, just go to medical school, no problem. Then you
Hmm.
don't have to worry about a job. So I had the PhD, or finishing, near finished, and then I decided to go to medical school. I joined the army to pay for the medical school. So
Wow, interesting. And I think your knowledge of biochemistry has always amazed me, Dr. Martindale. Whenever I've, listened to your talk, it really takes me back to medical school and but connects the dots really between basic sciences and clinical nutrition and what we do on a daily basis. So I think that definitely comes out in your practice, I'm sure.
oh yeah, I've been in a teaching situation my entire career, and I
Hmm.
feel if a person understands why they're in the situation they're in, like I used to teach a course in the clinical relevance of the Krebs cycle, and
Wow.
for the medical students, and they'd all just roll their eyes like, "Oh yeah, Krebs cycle, yeah, yeah, I know that." And then they'd realize that, man, I'm going to use this every day: acid base balance, and potassium flux, and everything else, and enzyme regulation. I started to realize this stuff is important. So
Mhm.
I've maintained that, and I get excited when I start talking about the Krebs cycle. Sometimes the residents roll their eyes, but I think they understand that that's good to know the basic science.
Mhm. Absolutely. Now, connecting that to the field of nutrition, do you feel like you rely on that knowledge as you provide nutritional care to patients?
Oh, absolutely. I run the nutrition section at the hospital. And
Okay.
so I have a resident on my nutrition service every day. So we see consults every day. And then in between cases in the operating room, I'll go and see a consult, you know. And
Hmm.
then we,
Hmm.
we also run the outpatient clinic. So we see short bowel patients and those. So,
Hmm.
I mean, I'm literally using nutrition every day of my life.
Hmm. Hmm. And I know some of those, because I spent some time with you at OHSU on the Nestle Fellowship. I know that some of those consults can be pretty complex. Can you give us an example of just complex nutritional scenarios or issues that you've encountered?
Yeah, I mean, it can be really anything. You know, difficulty in feeding because of motility, like something like scleroderma with GI dysmotility, or severe
Hmm.
gastroparesis, or
Hmm.
diabetes, or sometimes all of that. You know,
Hmm.
and then we have to use parenteral, and we end up with some liver failure, and so we change the lipid source around. And as you know,
Hmm.
well, with being a pediatric surgeon, the megavan issues and all those things. So,
Hmm.
I'm at a meeting now, in fact, here in Boston, that where the whole meeting is on the SPMs, which are derivatives of the fish oils.
Hmm.
Specialized drug resolving mediators, and
Hmm.
to me, that's really a field which is becoming very exciting. And I think the future for all of us in medicine is going to realize we can now use nutritional agents to treat a lot of these diseases, whether it be inflammatory bowel disease or dysmotility or, sepsis. We can, I think the age of nutrition now is really taken off because we've realized sometimes every medication you can think of has a side effect. But
Hmm.
guess
Hmm.
what? We have now, some of these lipid derivatives and protein derivatives that may not have too many side effects, because they're
Hmm.
natural products just delivered in the right time in the right way. So,
Hmm. Can you tell us a little bit more about SPMs? I know that's super exciting to you, and something that I've heard of as well, but I'm not super familiar with.
yeah, SPMs are what they used to be called resolvins, but then when they
Hmm.
realized there was more than one class of them, they decided there were so many of them, they just rename them. So
Hmm.
I guess about 7 years ago, they renamed them to specialized pro-resolving mediators,
Hmm.
and they're endogenously produced substrate end products of fish oil metabolism. So DHA makes the E source, so different class, and then EPA makes a different class.
Hmm.
And those mediators literally can influence almost everything we look at. We look at America today. What's killing us? Inflammatory diseases. Well, these regulate the inflammation. These enhance resolution of inflammation. The joke is here at this meeting. Of course, these are all uh, you know, resolutionists, as we call each other, because we believe in resolving the inflammation. We even have
Hmm.
these little buttons. This little button says "Start the resolution." I don't know if you can read it. Let me see.
Not really.
Yeah,
Yeah, I can
start the
see that.
resolution. Yeah,
Hmm.
and because I think we're saying before we can heal, we have to resolve the inflammatory process. Normal natural resolution, we used to think that the things just dissipated away, the pro-inflammatory cytokines and mediators just dissipated away until the wound healed, or the injured liver healed, or after a
Hmm.
stroke it just healed. Well, now we
Hmm.
know that once these are activated, they enhance resolution, by causing the macrophage to engulf the neutrophils, and they go into what they call phagocytosis. So it's a fascinating area where we actually may be able to see these chronic diseases which we've been treating, whether it be asthma, arthritis, atherosclerosis. All these diseases are just
Hmm.
failures of resolving an inflammatory process.
Hmm.
So
Hmm.
now, IBD, everything, you think about all
Hmm.
these
Hmm.
diseases, if we can get to resolve them. And now to be at this meeting with the guys who, discovered resolvins, it's
Hmm.
fascinating. Charlie
Hmm.
Sirhan, who's the sort of the father of the whole concept, is here, and we've spent lots of time with him. He invited all of his past postdocs and people he knows in the area. So
Hmm.
we have 12 speakers and 400 people registered for this meeting.
Wow.
just they're the guy world's experts in result. I've just enjoyed giving my talk yesterday. I gave sort of the clinical side of it, but a lot of these
Mhm.
guys are hardcore scientists, you know.
That's fascinating, Dr. Martindale. And as a pediatric GI doctor, I definitely have used dietary therapies to treat inflammatory bowel disease. It seems like it's a bigger deal in pediatrics more than adults. So, but it's something that we see, on a day-to-day basis. That we see dietary therapies work and help in dissolving inflammation. So that's great. It seems like it's already clinically applicable and maybe will become more so over time.
Oh yeah, once we
Uh,
learn how exactly to use these and how to deliver the substrate, it's going to be mainstream. You know.
mhm. Now I know, kind of along that same topic, I know we've had conversations about food and its effect on the microbiome, and I know that's something that's passionate for you, and you're passionate about that. I know that you have some experience with that at OHSU. Um, can you tell us a little bit more about that?
Yeah, man, the microbiome story, it's interesting over the years. It's become stronger and stronger. 25 years ago, I met people that were working with the microbiome, and I thought, this is very interesting. It's very complex because you're dealing with a
Hmm.
thousand species of bacteria. But
Hmm.
if this looks like it's going to go where it looks like it's going, it's going to be very exciting and something, again, we can use. And I think that, again, what are we doing in America? We're killing ourselves with what we're eating. As you've seen, all the major publications talking about all the processed foods, and we have ultra processed foods, and you know, 35 to 40% of the calories consumed in this country are processed food. And I think we've got to get back to what we evolved in. It's kind of nice to be able to talk about evolution, because I think we've had what, a million years. Man's been around, evolving, and we evolved with natural products. And in the last 100 years, we decided we know better, so we've added lots of chemicals to let them sit on the shelf. We've degerminated grains to take away the germinal center. We don't want any whole foods anymore, so we take off the husk and get pure white flour, no longer getting any fibers there. So we've changed our microbiome. And we know now from animal studies and even in some primate studies that if you put them back on a natural food diet, they do better in surgery. They do better in
Hmm.
trauma. They do better in prevention of disease. So I think that's something we got to get across to the American public, is we've got to quit eating stuff that comes out of packages that have been sitting on a shelf for 6 months.
Hmm. Where do you see that, like, practically speaking, with your patients who are undergoing surgeries or who are critically ill in the ICU?
Oh,
Um, how do you take that to the bedside?
yeah, we take that to the bedside. Like now we know that the basically colon cancer very
Mhm,
commonly associated with an altered microbiome. And so, for
mhm,
example, when we get ready to do surgery now, we will put the patient on a high fiber diet for a week prior to surgery, 10 days prior to surgery.
mhm,
We've got animal models that show anywhere from 2 to 4 days of up back to a high fiber diet.
mhm,
John Navarrete's done most of this work, a lot of this work. You put animals on a Western diet for a couple of months, okay, and the
mhm,
microbiome shifts to that Western diet microbiome. And
mhm,
then the question is, when you operate in those animals, they have increased leak, anastomotic leaks, they have more sepsis, the mortality is higher.
mhm,
But if you take them and put them back on a rat chow high fiber diet for just 2 days prior to operating, you lower the anastomosis rates, leak rates, and so we do that now in humans.
mhm,
We say, okay, for the next couple of weeks before surgery, this is the diet. We give them the little Metamucil wafers as part of the study. And we check their
mhm,
microbiome and see. And guess what? We're seeing fewer leaks in the patients who've got a high fiber diet. And that's been done by Alberti too. He's shown that.
mhm,
JAMA 2020 had a nice article. Patients in colorectal surgery that get a high fiber diet, in other words, getting the microbiome back to a more stable microbiome, not a pathobiome, but a stable microbiome, they have fewer leaks, they have fewer complications. So
mhm,
that's the kind of thing we're going to go back to. It's easy, it's inexpensive, it's not $1 million pill or $500,000 worth of monoclonal antibodies.
mhm,
It's easy,
mhm,
but
mhm,
people have to realize you got to go to the store and actually go to the produce department and buy some food that's got some fiber in it.
mhm, mhm. And I think, what we're referring to is probably what we would classify usually as prebiotics. I don't know if you use that term, Dr. Martindale, but sort of, encouraging the growth of good bacteria. Um, what would you, and I think we all have our different thoughts on probiotics, but what are your thoughts on that? And is there a role of
Yeah,
that in clinical medicine?
I think, you can spend a lot of money buying tablets, but you don't need that. If you buy just
Hmm.
good, healthy food, your body will make the
Hmm.
bacteria. The
Hmm.
prebiotic is the substrate and the fibers in the foods, whether it be whole grain foods or nuts or vegetables or fresh fruits and things. Your body
Hmm.
won't, the bacteria will thrive on that. It only takes 2 or 3 days to change some of the
Hmm.
microbiome back to a less pathogenic microbiome. And that's a cheap way to do it. They shouldn't go buy all these probiotics. It's a waste of money. I
Hmm.
tell people if you want to get some probiotics, just buy a good probiotic yogurt, and they're
Hmm.
available nationwide in every grocery store in this country.
So, Dr. Martindale, I know you see patients with like intracutaneous fistulas, and I think we've all like encountered these patients at times in our clinical practice or in the hospital. Can you tell me more about how what your thought process is when you're approaching these patients and how you manage them?
Yeah, as my career is sort of closing, you might say here, I now am only doing mostly fistulas. We've
Hmm.
become a fistula center. We do 1 to 2 a week now of intercutaneous fistulas or intravesical fistulas or whatever fistula it might be. And those are
Hmm.
very difficult nutrition because depending on where the lesion is in the gastrointestinal tract, we may or may not need parenteral nutrition, and then we
Hmm.
may or may be able to feed distally through a pump system. So there's
Hmm.
lots of ways that these are a challenge nutritionally, and so but they're very exciting because it takes a lot of planning, and you have to get the person
Hmm.
perfectly tuned for them to be able to tolerate a 6 or 8 or 10 hour operation. And then
Hmm.
sometimes, I would say our average fistula duration of surgery is about 7 hours. So
Wow.
it's a long operation, very tedious, but you can really save people's a lot of grief, you know,
Hmm.
if you do them right.
When you say getting them like tuned up and in the right spot, is some of that nutritional like
Oh, it's
rehabilitation?
majority nutritional. We've learned
Hmm.
now that we've gone back and forth to how much protein to give, and maybe there's some
Hmm.
middle ground. But
Hmm.
in these patients, clearly the protein and resistance exercise is the key.
Hmm.
We really need, you can give all the protein you want, but if you can't turn on muscle protein synthesis, it's not going to help you. So unless you're using the muscle with the resistance exercise, you're not going to
Hmm.
uptake that protein very well. And that's been shown very well recently that
Hmm.
resistance exercise is the answer to getting this. And whether it's preoperatively for a month or
Hmm.
postoperatively, part of my gig now is doing the pre-op preparation of patients for major surgery in our clinic.
Hmm.
We have a pre-op clinic, and
Hmm.
that whether it be neurosurgery, orthopedic surgery, general surgery, all of those patients come to our pre-op clinic. That clinic requires a aggressive dietitian who works in our clinic, who goes over
Hmm.
what their diets are and what they should eat in the next month. Most of
Hmm.
our protocols require 4 grams of fish oils a day, based on
Hmm.
work by McGlory showing we can decrease the loss of protein during immobilization, muscle protein, and it enhances rate of recovery of muscle protein synthesis. So it's a very aggressive nutrition plan, but all that's part of an exercise program. If they walk in a walker, that's fine. If they don't get out of bed because they've got some other issue with mobility, especially the elderly population, we give them hand weights and things they can do with their upper body, because it doesn't take a specific muscle to use. It just takes muscle utilization to enhance muscle protein synthetic ability. And that works throughout the body, not just the muscle being used.
Interesting. Okay. So any resistance exercise is better than none, is what you're saying.
Absolutely. Even if it's just
Mhm.
upper body, little weights, I tell them if they, can get 1 and 2 pound weights and use those, or
Mhm.
just get a can of soup, out of the cupboard and lift
Mhm.
that if that's all they've got. You know.
Interesting, Dr. Martindale. I mean, I think we obviously deal with different populations. I deal with a pediatric population, and your population is obviously a different older. Um, how do you get them motivated to get into resistance exercises? How do you explain that
Well,
to
it takes a sales pitch. You've got to say, look,
them?
how much do you want to get better? And they got to get buy-in. If they don't get buy-in, if they just lay there in bed and don't do anything, I said, well, we're not going to do your surgery. we're going to wait because you're not ready. Your body's not ready to tolerate this operation. And usually they're so sick of not having a I just recently operated on a little child, 2-year-old, who unfortunately got run over. And we spent 13 hours in his belly, but kids, you don't have to worry about motivation. They want to get back up and play. And it was pretty shocking to me because I don't operate on very few kids. I operate on very few children, but they called me over our children's hospital to help out with this case. And so it was quite a shock. You don't have to motivate those kids. All you can do is just, they want to get up and play. So if they're feeling reasonably well, they get up and play.
Yeah,
But that
definitely
fish
designed to work.
did well, yeah.
Yeah, that's awesome, Dr. Martindale. Thank you for sharing that. So, you kind of touched on this briefly here about, SPMs and I guess the future of clinical care. Where do you feel like nutrition is going, like in general? I think you've been around Aspen for several years, been in the field of
Yeah.
nutrition for several years. What's the future?
I think we're in a point now where it's our job now is going to be sell it to the public because we have data. We've got the data to say what they need and what they what we can do. So the key now is just getting it sort of roll that out to the public so they accept it. In the fellowship, you mentioned already the Nestle Nutrition Fellowship. It's in our 13th year, teaching 6 or 7 young physicians a year. And there are a lot of people out there now, like yourself, that are so we're getting there. We're almost there. I think we've got the data to make it work. And so it's now, I was a 42nd member of Aspen. My number is 00042.
Wow.
I was a grad student when I joined Aspen, and I've watched it grow, and I think it's got a chance to really make an impact. But it takes work, to do it.
Yeah, I agree. I think, Aspen's a great organization. I love the, multidisciplinary collaborative nature of everybody at Aspen. Looking forward to the meeting later this month. I will you be attending, Dr.
Yeah.
Martindale?
Oh, yeah.
All right, awesome. Well, any final words here, Dr. Martindale, before we wrap up?
No, I think that sounds great. I think I don't have anything else to say. I think
All right,
we're
Dr.
on good
Martindale.
standing. I think the key is data, and that's what we have now. So we just got to get the word out.
All right. Well, excellent talking to you, Dr. Martindale. Thank you for spending this
Good talking to
time.
you, Vikram. Enjoyed it.
All
I'll
right.
see you in a couple weeks at Aspen.
See you in a few weeks.
Okay. Bye-bye.
Bye. Bye.